Good morning, everyone. I'm Gavin Kelly, Executive Chair of the Resolution Foundation, and I'd like to welcome you to this morning's event, The Cost of Poor Health. In fact, I'll read the whole thing out. What does rising health-related benefit spending mean for the UK and its next government? It's worth saying that, because that is a key question, and this is one of our series of election briefing events, of which we've had a number, and we've got another one next week I'll tell you about at the end. Now, elections should be a good moment to have serious conversations about big issues facing the country. That, in some ways, that's kind of the point. But I think it's fair to say they don't always lend themselves to very careful assessments of really complicated social issues. And I think we're sort of living through that at the moment. The issue that we're discussing today, both the kind of rising prevalence of ill health and disability and also what that means in terms of benefit spending, is certainly a complicated issue. And it's also a big issue, as you're going to hear from some of the speakers, in terms of some of the potential fiscal consequences. Now, it has made an appearance in this election, but I don't think it has done so in a particularly considered way. We've had one party, the Conservatives, who have said they're going to make £12 billion of cuts to working age benefits. They've suggested that those cuts will be centred around disability benefits, and that money will fund a tax cut. Although they've also said a bit of that money, and a relatively small proportion of that money, will fund increased provision, mental health provision. So that's what we've heard from them. And it's important to say, and those cuts are supposed to come in very quickly, and indeed are supposed to start yielding £4 billion of savings within 9 months of today. Right. So this is like a lot of money yielding savings extremely quickly. That's based on the documentation that's been published. The other party, Labour, hasn't really said very much at all. They have said that they want to reform the work capability assessment within universal credit, as have the Conservatives too. Although it's more to say they haven't scored any savings, I think I'm right in saying, in their manifesto documentation from that. But they really haven't said much at all. And neither party has set out really why they think we're seeing these trends in a serious way, nor have they given a sense of what a rounded strategy, which is focused on both causes and prevention and kind of the different aspects of a potential approach. They haven't set that out either. So we haven't got that in front of us. But that's okay, because we have the next hour or so to try and do our bit to put that right. We're not going for easy headlines. We're trying to examine what's really going on and to start to think about what could be done about it in a considered way, not least to sort of shape our thinking and the thinking of other people in this discussion in terms of whatever it is we're going to develop as work goes forward post-election. In order to help us do that, we really do have a great panel. I'm really actually excited about this and looking forward to this discussion. You're going to hear first from Louise Murphy on the far right. Louise is a senior economist at the Resolution Foundation. She does loads of work, labour market work, with a particular focus on inactivity, ill health, and so on. So kind of the key person here at the Foundation. Then we're going to hear, I'll do it this way, from Paul Gregg. Paul is one of the country's leading experts on labour markets and the interaction between labour markets and social policy more generally. He used to be a member of the Council of Economic Advisors in the Treasury, a professor at Bath University. Far more glamorously, he was a research associate at this place, and at the risk of causing him to blush, is something of a poster boy for people who are serious about doing academic research but want to sort of apply it in the world of public policy. So it's always good to have Paul with us. Then we're going to hear on my far left from Dr. Sarah Hughes. Really pleased and delighted to have the Chief Executive Mind here today for this discussion. Sarah is a trained social worker, has worked in mental health and criminal justice for 29 years, it says here, and has managed a whole range of community and secure services. So really, thank you for making the time to join us, Sarah. And last but definitely not least, we're going to hear from Eddie Graham. Eddie is Director of Advice Services at Z2K and has loads of experience working across the sector. And I'm not going to list all the organisations, but a lot of frontline organisations providing advice to members of the public and benefit claimants and so on. So really good to have your perspective too. Thank you, Eddie. You can ask questions, as usual, at these events at slido.com. For those, and I know we're being joined by lots of people online, so please do take part, put your questions there. And if you're if you're still a tweeter, I know that's old speak, but if tweeting or whatever it is your thing, then this is the cost of health, I believe, is the hashtag, if you still do hashtags. And that is enough from me. I think we should get going. Louise, take it away.
Perfect. Great. Thank you, Gavin. And I'd like to start by thanking my co-author, Lindsay Judge, as well as the Nuffield Foundation, who kindly funded this report. And I'd also like to pay thanks to the 10 welfare rights advisors, some of whom are in the room, who kindly shared their expertise and opinions in a roundtable we heard. And if you read the report, you can see some of their insights quoted throughout the report. So as Gavin said, this topic of health-related benefits has been growing in salience and has certainly caught the attention of politicians. And I think a clear starting point to any of these discussions is that the spend on these benefits has increased over the past decade or so and is set to increase further over the forecast period until the end of this decade. What we show on this chart is the spending on these two different types of working age health-related benefits. In the yellow-orange colour, what we can see is incapacity benefits. These are benefits paid to working age people who are out of work with a long-term condition or impairment. And these are means-tested benefits, so people's incomes and savings are taken into account. What we can also see is that other type of working age health-related benefits, shown in blue, and these are disability benefits. These benefits are not means-tested, so people can receive these even if they are in work or have a high degree of savings. And these benefits are really designed to reflect the additional costs that many people with health conditions or disabilities face in day-to-day life. And what we can see is that the spending has increased by around £15 billion in real terms over the past decade, and today stand at around £43 billion of spend each year. But what is perhaps of more concern to politicians or people in the Treasury is that this trend is set to continue over the forecast period. And so in the 6 years taking us to the end of the decade, what we see is that these benefits are expected to rise by a further £21 billion in real terms. That's around a 48% increase. And to illustrate that or put it in its wider context, what we can do is show how these benefits compare to overall GDP. And what we can see is that a decade ago, working age health-related benefits accounted for just over 1% of GDP, 1.2%. Currently, that's increased to around 1.6%. And by the end of the decade, that's set to be over 2%, so 2.1%. So again, that shows just how significant these benefits are. But we think it is important to split out these different benefit types if we really want to understand what's going on and think deeply about the trends. First of all, what we show in this chart is the trend in disability benefits. And we can see that this has been a long-term trend. There's been a long-term increase in spending on these disability benefits. By the end of the forecast period, we can see that spending is set to be around 600% higher in real terms than it was in the mid-1990s, and that this spend is driven both by a rising caseload, so that's more people in receipt of these benefits, but also a higher average award. On the other hand, when we look at incapacity benefits, we can see that the trend is much more recent. It was only really around 2019 that the real term spending on these benefits for working age people was higher than it was in the 1990s. And I think what will be of interest to policymakers here is just that the forecast period looks so significantly different to trends over the past decade. And I think it's also worth pointing out that when we look at these incapacity benefits, the story really is all about caseload. So it's not that the average award that people are getting has increased when we look at it in the round. It's really that we have a higher proportion of people receiving these benefits. And so it's clear that there's something going on. This focus isn't unjustified, but I think, as Gavin said, what has often been missing is that chance to really dig a bit deeper and understand what might be driving these trends. And so we'll hopefully start to dig into that over the remainder of this presentation. The first thing we think is important to acknowledge is that our working age population is getting older, and this on its own is driving up the caseload and spend on these working age health related benefits. What this chart does is looks at children and adults of different age groups and looks at how the caseload for health related benefits has increased over the past decade. And what we can see on the left-hand side of the chart is that for the children and younger adults, population changes, population rises haven't really played an important part of the story. Instead, it's really just that a growing proportion of the population are in receipt. But when we look at older adults in the red box, we see that population changes here are important. And there's two things going on. Firstly, just the average age of our working age population has increased with more people in that 55 to 64 age bracket. And we know that this age bracket is one where the prevalence of disability is relatively high. But what we also see in the kind of right-hand bar is that due to the rising state pension age, we now have a significant number of people aged 65 and over who are in receipt of these working age benefits because they now are classed as being working age. So whereas previously they might have been in receipt of the state pension and perhaps pension age benefits, they now are in this working age caseload. And overall, these demographic changes, these population changes, account for around a quarter of the overall rise in caseload for these working age health related benefits over the decade. So we think it is a significant part of the story. But there's another social change that we think needs to be acknowledged and actually is often missed from some of the narrow discussions around disability and health-related benefits. And that is simply that over the past decade, there has been a huge shift in the number of adults across our country who report a disability. What we can see in the green part of this chart is that when we look at all working age adults, the proportion who report a disability has increased from around 16 to 23% over the past decade. And I think we really do need to stop and acknowledge that around a quarter of all working age adults report a disability. And when we put this debate in that context, then perhaps it's not surprising that we're seeing such shifts to the health-related benefit system. What this chart also shows is that for certain age groups, the change has been even more significant. For example, with younger adults, age 16 to 24, what we see is that the proportion who report a disability has doubled over the past decade. And when we take all of this together, when we look at these demographic and social changes in the overall prevalence of disability, we can see that explains around 4/5 of the overall rise in working age health-related benefit caseload. So put simply, it looks like the trends we're seeing in the benefit system are largely mirroring wider shifts that we're seeing across society. But that doesn't mean that the benefit system isn't important or we shouldn't look at it more deeply. What we have heard in some of the debate or discussion in recent years is an idea that it might be easier for people to claim or be awarded these benefits. But what this chart shows is that we really struggle to find any evidence that that was the case. And in fact, what we see here is that for new applicants to PIP, the main working age disability benefit, for both those with physical health conditions in the darker blue and those whose main condition is a mental health condition in the paler blue, the proportion of applicants whose claim is awarded has remained pretty stable over time. You can see some slight fluctuations year on year, but there's no huge trend at play. And that's also true now on the right-hand side of the chart when we look at those people who have moved on to PIP from the old style benefit DLA. Some of those people move due to a change of circumstances. For example, if they turn 16 and move from child DLA onto PIP, some of those people are moved randomly as the DWP try to shift the caseload. But again, quite remarkably actually, the overall award rate has remained pretty constant over time. But we think that there is an aspect of the benefit system that is worthy of attention, and that is broadly that benefit choices and policy design over the past few decades in some cases have been pretty poor, and that those choices affect people's incentives to claim health-related benefits. What we show here is an illustrative case study of a single adult who's out of work and receipt of out-of-work benefit support, for example, through universal credit. For a single adult, their monthly income stands at around £400 a month. But what we can see is that if they are awarded the health-related element of universal credit, so that's the main type of incapacity benefit support, their monthly income doubles to around £800 a month, a huge transformation to their living standards. And again, if they also are awarded this sort of standard rate of PIP, the main disability benefit, their income increases even further to around £1,100 a month. And so I think it's pretty clear that for any given person who does have a health condition or disability, it really makes sense for people to go through that application process and claim these disability benefits due to just how much of an impact it could have on their finances if they are awarded. And the related thing that we thought is important to bring out is that some of these poor policy design choices have really been kind of put into the spotlight in recent years due to the financial pressures of the COVID-19 pandemic and the cost of living crisis. What this chart shows is that the standard rate of out-of-work benefit support has fallen in real terms over the past decade or so. So there's been an 8% fall since 2010. But we think this chart shows sort of two additional things of, not only was there that kind of gradual decrease over the 2010s, for example, due to the benefit freeze, but more recently we've seen the shock of the introduction and then the sudden removal of the £20 a week uplift to universal credit that really caused people's family finances to change quite dramatically over the course of a few months. And then what we see at the end of this chart is that the cost of living crisis has really impacted people in low-income households. So in this chart, in the brighter green, what we show is the real value of these benefits using the overall rate of inflation that applies to the economy overall. But in the darker green, we look at what that is for those households on lower incomes who spend a greater proportion of their income on essentials like food and energy, where we know that there's been rapid increases over the cost of living crisis. And we can see that when we use that measure of inflation, people's finances, the value of benefits has been squeezed even more. And so to conclude, we think that there are some key lessons that whoever the next government is can learn when thinking about this topic. First of all, we think that it's really important to place discussions of health-related benefits in their wider context. It really is important that any government and us as a society really get to the bottom of why we're seeing these trends in disability. Why is it that there are 3 million more working age adults reporting a disability now than there were a decade ago? In doing so, we think that the government must acknowledge that any policy response must extend past the benefit system and also, for example, include work focused on employment and wider public services. Secondly, we think it's really important to learn from the past and think about policy decisions in a considered way instead of sort of thinking of jumping ahead and thinking about cuts or simple reforms. We think that the strategy over the past couple of decades can be described as a whack-a-mole effort of cutting or squeezing benefits in certain places in an effort to save money. But instead what we're seeing is that pressure popping up elsewhere, in this case in the health-related benefits sphere. And that really doesn't look like a strategy for success. And finally, and importantly, we think that any government must just bear in mind that when making policy changes in this space, decisions must be taken very carefully. Disability benefits do a good, albeit not perfect, job of protecting people's incomes, and so cuts in this area have the potential to leave many disabled people in financial insecurity. Thank you very much.
Thank you, Louise. I mean, I know it's for the keen, but there's a lot of detail in this report, which, I mean, that was a great summary of it, first of all, but there's a lot more detail in here, so do have a look if you can. Okay, Paul, give us a bit of context and a bit of a sense of your policy directions.
How do I get my slides? Right, hi guys. So following on from what Louise said is she made the distinction between disability and incapacity, the incapacity being about what she called the caseload. That's what I'm going to talk about. I'm going to talk about worklessness for health-related reasons, which includes me. Right? This is the first time I've done any work for 4 years, and they're not paying me, so it counts as voluntary. But the kind of punchline is, that, and it was sort of there in the charts, is that since the start of the pandemic, the caseload of economic inactivity for health reasons and the caseload on incapacity benefits has risen by 800,000. And that follows 20 years when the numbers were falling. Slowly, but they were falling. So that reversal is what's driving a huge part of a broader problem. And I just want to sort of emphasize is that there's two conversations that we need to have here. We can talk about benefit cuts. And if you're trying to do stuff quickly in terms of saving money, that's where you may go. But there's another narrative which is about denied economic opportunity. Yeah, and it's got parallels with other groups who are marginalised within the labour market who have, through welfare reform and social policy, been brought into the labour market over the last 40 years. And so I want to touch in some sense about what the lessons are there about how you can bring economic opportunity to marginalised groups with a focus on health-related problems rather than directly borrowing from other kind of policy. So that's what I'm trying to do. Okay. And that's not the right way. That's not the right way. Okay. Okay. Well, we'll get back to that. Right. Okay. So what I'm going to sort of talk about is a bit of history, how we got here, focusing around economic inactivity, the scale of the problem, how the problem works in the sense of the characteristics and the dynamics around economic inactivity and welfare receipt, and what lessons we can draw out in terms of making the policy kind of changes, which would be potentially able to, over a relatively long period of time, reverse the kind of rising caseload that we've seen and bring economic opportunity to a large set of middle one, yeah? Okay. All right, fine. That doesn't work. Right. So that's the data, right? Okay, I'm a statistics kind of guy, so I'm going to give you a little bit of data. I'm not going to focus on it too much, but I want to make a few kind of points. 2019, just before the pandemic, we had the highest employment rate in the UK we had historically ever had. We had the lowest economic inactivity we had ever had, probably since the late medieval period where everybody had to work on farms and stuff, right? That we had an economic inactivity rate down to around 20%. This was a huge period in a sense of success. But there had been two massive changes over that kind of period. Firstly, if you roll back to the kind of era of full employment, nearly all men worked. Something like over 92% of men worked, but only half of women. So inactivity then was dominated by women who were looking after the family and home, and that the broader forms of inactivity were relatively rare. Running forward, we've had a massive decline in male employment and an even more massive increase in female employment, which has driven the overall inactivity down. But the causes or the reasons for that inactivity have profoundly changed. It's no longer mothers looking after family and home. The biggest increase is actually students, right? Students who don't work, right? That is the biggest source of increase, but there are also sizable contributions of health-related incapacity and early retirement. Okay, so that's kind of point one. Point two is what I've just sort of said, which is that since the pandemic, is that prior to the pandemic, economic inactivity for health reasons was falling, and it fell by around 400,000 over 20 years, right? Slow, but it was falling, right? And, but we've had the rise, which has sort of eaten that fall in just 5 years, since the beginning of the pandemic, 4 years, right? And the scale of that change is scary, and it may have stopped. We may have got to the point where that rise has halted, but it may well not be the case, and actually there's still some rise to happen within the system. Okay, so fine, that's just what I've kind of said. The way to sort of to draw this out is that there's 4 key eras of economic inactivity for health reasons or incapacity, and you can show it both in the economic sphere and you can talk it in about the benefit sphere, right? Was that way back in the period of full employment, the proportion of the population who was in receipt of working age incapacity related benefits was just 2.8%. Okay? The 1980s recession caused a massive shakeout of people with health related problems. So in that full employment period, much of the kind of health related problems and issues were occupationally related. We had strong trade unions and full employment, and that lots of people were in work on what I will call light duties, right? And that was frequent absence, right? Doing less intensive work, but still employed. The 80s recession caused a massive shakeout of that kind of labour, what I'll call work intensification. Right? It was that work has intensified, and the intensification of work drives out people who are somewhat marginal in terms of their capacity to work into economic inactivity. But they didn't turn up immediately in incapacity-related benefits. They started in unemployment benefits. And then 2 things happened: restart and JSA. If you like, work conditionality in the welfare system, work search conditionality in the welfare system, cause a massive migration of people from unemployment-related benefits towards incapacity-related benefits. So that between 1985 and 1999, that kind of period, we saw almost trebling in number of people, proportion of the population in receipt of working age incapacity-related benefits. So that was the kind of the big shock to the system, or the first big shock to the system. It then went into sign of slow reverse, right? And that people started to drift away from these kind of benefits, right? And I just want to emphasize this, is that it wasn't because those people who were shook out were coming back into work, right? What it was, those people have long since aged out of the system. They retired or quite often died, yeah? It wasn't a move back into employment. It was a reduction in the inflow, right? Yeah, and then the existing stock aging out, right? And then to kind of emphasize that flows are the crucial way to think about this particular kind of issue, is that what moves things is the inflow, right? The outflows are slow and of long duration, right? Fine, okay. Right. And then, sorry, the final kind of point of the eras was that, so we had the period of lows, incapacity benefit relation, the big rise in the 80s and 90s, a slow, long, slow decline, and then the current shock. That current shock, if you like, that's just been happening has doubled the inflow rate. Yeah, the inflow rate into incapacity benefits has more or less doubled from just over 22,000 to something over 40,000 a month. People who are on incapacity-related benefits have very low exit rates, which means the expected duration is 10 years plus once you're on it, yeah? Right? And what outflows back into work that occur in the first 2 years. That after 2 years, the chances of somebody leaving incapacity benefits into work are negligible, right? That creates a window. We have a window to talk about policy in this space, and that window is a year to 18 months before leaving employment, going on to sick pay, if you like, and then about 2 years after, right? And that's where policy has got to focus if we are trying to reverse the rise in incapacity-related benefits or economic inactivity. Right, so that's the kind of policy space that we've got to work on, right? And so pulling that sort of together, we can talk about the key policy dimensions. And here I want to tell you what I think is really important, right? Is that we need to not just be focused around policy in incapacity and disability-related conversations. We need to learn important lessons from other groups who have been successfully brought into the labour market over 40 odd years, mothers being the biggest but not the only kind of group, and how policy made those kind of differences, and try and apply those kind of policy insights into this particular kind of dimension. The first thing we need to say then is we need to be talking about public health. There is no doubt within this conversation that the level of the condition of public health has been deteriorating, right? The big drivers of health-related issues are obesity and diabetes on one side and mental health on the other. Yeah, and so we need to be thinking about policy intervention to address those kind of public health challenges, right? I also just read about how kids are getting shorter and fatter, right, through the same kind of issues. We need to be having a sizable and significant redesign of public health interventions. In my head, that is a sugar tax, right? And the sugar tax being used to fund the kind of investments in the other kind of services, mental health services, and what I'll go on to talk about in terms of programs and supports, right? As the only kind of serious way we're going to get revenues. There's no revenues around, so we need to talk about revenues, and we need to invest in work-related supports. The second is the employer contract. What I didn't say and should have done a little bit before is that once you've been out of work for any length of time, the job that you come back to is way worse than the one that you left, right? It's typically after about 2 years, 20% lower paid, far more likely to be unstable, insecure, and employers less likely to be prepared to engage in work-related supports for people, if you like, the conditions, and accepting and sympathetic to the conditions that they face. I want to draw a kind of lesson here in terms of what happened with maternity. Maternity leave runs a year, sickness leave runs 28 weeks, right? And, you know, serious kind of conditions need to, in the sense, expect to be taking serious periods of time to reverse. In addition, maternity leave is both a paid period and an unpaid period. Yeah? We don't have the equivalent for health-related problems of a period where you are not being paid by the employer, but you're still effectively on contract with that employer, with the right to return part-time, and right to return with workplace adaptations. So we need to think in this kind of space about having an extended period where we are working with individuals and employers for the pre-existing job rather than just trying to find people new jobs, right? Because, as I say, the quality is likely to be much higher and the employer more sympathetic. Okay. We may also think of, in a similar kind of space around people who are coming off in unemployment benefits, the idea of an intermediate space where we're trying to do something serious. Programs in this kind of space have been pretty disastrous. Yeah, we've not had major success with programs, but within that we do have some elements which have been reasonably successful. Access to work, which is workplace adaptation, some success. Condition management, not tried heavily, but it has had limited success, and it's worth exploring again. Job coaches, engaging with participants and employers to try and get matches to help people and to help people stay in work, not a huge success on its own. So we need to be thinking about that kind of space, but we need to be also thinking about something more. So within the kind of intermediate space where we've got people connected still with employers, we need to be using these kind of programs, but we need something more. The lessons we've got from other kind of groups is what you can talk of is, in a sense, work placements or intermediate labour market is worth experimenting within this kind of space. A lot of people are going to be resistant or concerned about moving back into work straight away. And the idea of what I'll call, if you like, work trials of high quality employment, right? So we're talking about the same kind of stuff that we've been done in Future Jobs Fund previously, or traineeships for more recently, where you're trying to locate people in if you like, with employers, but in circumstances which are relatively protected and supported by the state, in order to facilitate the person to be able to make the transition into unsupported employment, right? Okay, we've got good success with this kind of stuff, but what the danger is to create, if you like, long-term supported employment, which we used to have for certain kind of groups and so on. And that was not hugely positive, but we can look at, if you like, temporary spells of trying to get people reconnected with the labour market through programs. I am wrapping up. 2 more points, the last 2 points, right? To get people to participate in that and to get employers to participate in these kind of programs, those 4 kind of programs and supports as a package, we need to look at incentives. We need to look at incentives for the participants and for the employers, and that's going to include some kind of financial kind of story, right? Employers should be concerned about the destinations, right? They're not just providing something then, they need to be thinking positively about where the person's going. And so we need sort of outcome-related funding on the employer side, not just the participants. And then finally, something which I just wanted to sort of lodge, because it's kind of true but almost completely untalked about, which is that we're not just talking about the person who has health-related issues, we're talking about partners. And in many cases, we're also talking about parents of children with health-related issues. Yeah, and this is an area of economic inactivity where it's not the person, but it's a partner or parent, right? That is really massively under-researched. We really know very, very little in this kind of space, right, about what can help, right? But the numbers are quite large. Employment rates of those people with partners with health-related problems are massively lower than the rest of the population. I mean, there's 2 big issues there. There's work incentives, which I've sort of touched on, and then there's caring responsibilities, right? And we need to be doing the research about, if you like, what's the mix of those kind of issues and what can we do about it, right? It's also worth noting that the employment rate, the transition to employment rate of those people with health-related problems is higher when their partner's working, yeah? There is a positive synergy that which suggests there is a work incentive issue, right? But this is an additional kind of point which broadens the debate, and I think that's important, away from just focusing on the individual and focusing on families with health and disability problems. Thank you.
Thank you so much, Paul. I think that was brilliant in giving us the history, giving us a sense that the benefit system is a system, and you can't just look at one bit and there's kind of interlinks between different bits of it, but also just broadening out the policy conversation that we need to be having in a really helpful way. So that has set us up. Thank you. Sarah, over to you.
Well, thank you. It was great to hear you both, and really appreciate the insights. And it was really fascinating in the report to kind of think about the implications of working age, that expansion. I hadn't quite thought about that in this way, because mostly in mental health, what we understand the primary issues are the social determinants of health. And I think that whilst the report is really important and definitely has kind of furthered insight at a really important time as policy is being evolved, I think we have to acknowledge that the health of the nation has been hugely under pressure for the last 15 years. And the role of health inequalities, the work that Marmot has done, has been really clear about making those links. And in mental health, we see that incredibly starkly. And I guess, we understand that the experience of the pandemic is one that we are still not really coming to terms with. And I think we all naturally really kind of want to run away from it. I think most of us want to see it in the kind of history books for sure. But the reality is that we haven't really kind of understood the impact that it's had on the psychology of the nation, on children and young people's mental health, on those students who are taking themselves out of the working economy. And we also know that poor, limited access to services, poor outcomes when you get into services, and I always use the example of, we could provide, if you think about somebody who's living with psychosis, for instance, we have some of the best treatment in the world for psychosis. If we can get in early enough, we can absolutely radically change somebody's life. But if that person is coming for treatment for their psychosis, but going back to a bedsit that is cold, damp, that they're isolated, then the treatment that we're providing is basically being thrown into a leaky bucket. And that is probably more the case now than it ever has been. And so we're seeing all of these contributing factors get us to this point. We at Mind are hugely concerned about the numbers of people with mental health problems dropping out of the workforce, because in our experience, the majority of people with mental health problems want to work. So it's about what is happening in workplaces. What is happening to their ability to get the support they need? We know, and Federico's here from the Centre for Mental Health, could very much share a lot about individual placement support, for instance, which is an intervention that gets people into work and has really high success rates. And that's because we're linking up service provision with their employment, making sure all of the bases are covered. So the trap that we've got here, and we really want the new government, whoever that is, to really understand that it is absolutely possible to get people into work, keep people into work, if we can do a few things. And those few things are related to service provision, they're related to stigma and discrimination, and ultimately they're related to workplace flexibility that allows people to kind of thrive in workplaces. We know the answers, it's not that we don't know, and I think that we don't want to get into a trap where we're thinking this is a hopeless case. It absolutely isn't.
Great. Thank you so much. Important that we keep that note of optimism running through, because you can get sort of battered, if you like, by the statistics and the trends. So thank you. Eddie, over to you.
Thanks. So at Z2K, we advise about housing and welfare benefits, and we support around 1,500 people a year. And 80% of our clients report having a disability or a long-term health condition. And most of our work with challenging decisions relates to personal independence payment or universal credit health element that Louise referred to earlier. And there's several things that we've seen in recent years which I think are pertinent to the report, and some of them captured by the report. So I would say, firstly, obviously, austerity. So some of the graphs, I think, in the report show a marked change around the time when austerity starts to bite, 2013, 2014. And as the welfare state has been punctured and the holes have sort of been more and bigger, and it's just got generally less generous, harsher and more punitive, many claimants have kind of been forced to make a choice, if you like, to jump onto, if you like, the lifeboat that is PIP, basically. So thinking back 15 or 20 years ago, somebody who left work in their 40s or 50s, maybe done low-skilled jobs, maybe no reasonable prospect, as Paul alluded to, of kind of getting back into kind of higher paying employment. They might have claimed job seekers allowance, they might have gone on the sick, as you would call it, and they would be on in what was used to be called the work group, basically. So they get a little bit extra money. That has been abolished, basically, and it's created this massive division between people who are out of work, whether they're on JSA or universal credit, and not kind of classed as sick enough, and the people who can get what's called the limited capability for work assessment, what we used to call the support group, so the most severely disabled. The financial disparity between those two groups is now enormous. It was one of the slides. So more people who, if you like, might have been happy on a lower level of income are now trying to jump into the more severely disabled group. And as advice workers, we now see every week, we are advising people who 10 or 15 years ago we'd have said, yeah, you're unfit for work, sadly you can get this extra amount of benefit. That's no longer there now. We're trying to get them into the most severely disabled category with quite a lot of success, because there is an army of welfare rights workers out in the country, and we have a system which is all based on law. We have an appeals system that we can use, and so we can challenge decisions in a way that you can't in lots of other fields of social welfare law. You don't need to be a lawyer. We have a specialist judiciary that make binding case law, and it's actually been very successful. And so many more people are now classed as in the most severely disabled group, who 20 or 15 years ago, or even 10 years ago, just simply would not have been, basically. And so that's why, if you looked at the current government, if we can still call them that, their most recent proposals pre the election announcement about reforming incapacity benefits very much focused on that, basically. They believe that lots of people are in that group who shouldn't be, basically, and they want to tighten that group or kind of remove it altogether by getting rid of the work capability assessment, full stop. So that is something that we've seen. Similarly with personal independence payment, although expenditure and some of the caseloads haven't changed over recent years, that is in the face of reforms which have been aimed at driving down expenditure and caseload. So when personal independence payment was introduced 10 years ago, the explicit aim was to reduce expenditure by 20%. That's failed completely. Expenditure has actually gone up, partly because it was kind of badly designed, really. So I think one of the examples in the paper is on DLA, you used to have this thing called the lower rate of the care component, which would be generally people with mild to moderate mental health problems and maybe intermittent physical disabilities. That's completely gone, but of course those people still have needs. They're still excluded from the labour market. They're still facing a life of poverty, basically, on benefits. So they've tried to get personal independence payment, and they've been quite successful, basically, and their advisors have been successful PIP was designed to help more people with learning disabilities and mental health problems, and in many cases that's kind of actually been successful. So the design of the benefit system combined with austerity has in a way has pushed more people to try and grab and jump onto whatever sort of life rafts are available, because the choice at the minute is, if you're on the basic rate of universal credit, if your housing support doesn't cover your housing costs because of the squeeze on local housing allowance, if you're benefit capped or subject to the bedroom tax, you are living well below the subsistence level of benefits. And I think this is one of the themes, obviously, is how moving forward about the design of the system, it really has to be a whole approach. Because reforms we've had in the past, so even like employment and support allowance in the 90s, and when the Labour government introduced that, they really thought they'd found the answer to all the problems, that they could have a combination of conversations with people about their health, combination of financial support, conversations about how to move into work, and an increase in conditionality. They really thought that they'd found the answer, but the problem is that when the answer didn't arise as quickly as they thought, all the kind of fluffy bits get dropped and you're just left with the sanctions. And I think that is very clearly where the last government was focused on, increasing sanctions, conditionality, the punitive approach. And hopefully going forward, the government can take a step back and say, well, how do we support the people who want to remain in work or are close to the labour market? How does the benefit system incentivise them, give them enough money to live on so they are ready to move back into work, rather than, if you don't jump through all these hoops, your benefit is going to be cut, you're going to be at the risk of conditionality, which is another big driver. Many people are claiming sickness benefits or claiming that it's just to avoid conditionality, just to avoid having to go to work-focused interviews and apply for jobs that they're never going to get. there's a whole range of things which I could talk about for quite some time, but I won't. So I will kind of like, I'll wrap up there.
Thank you. That
Okay.
really, really helped. Thank you, Eddie. And I think that if we get time, let's come back to this question about the very high stakes nature of the decision on benefits in terms of the system that we've evolved and whether or not that's the right way forward or whether we might think of other ways forward. Now, we don't have all that long, but let's just bring up the poll just to kind of get a sense of where you lot are at on this basic question. Can we bring that up? So the question we're going to ask you, vote online, you know how to do it, is what's the biggest factor driving the numbers of health and disability related benefit claimants between a shift in social norms, which we should touch on. We're all getting older. Louise has told us that's definitely something that's going on. Basically, the state of the NHS, leading the people who would have had some problem deteriorating basically because of what's been going on with the NHS, which is partly a COVID issue, but not just a COVID issue, let's be clear. Destitution. Basically, the alternatives are so bad that the incentives are just very, very powerful. And just the wider design of the social security system. No, you can't say all of these. We want to know what you're...
Yes.
might be tempted to. Give us your take on that. Okay, we'll come back to that. Remind me to come back to that before we let people go. Now, we don't want to go on too long, but let's we've got about 15 minutes or so for discussion, and I want to make sure that our audience comes in. I'm just going to start with a couple of quick questions. I mean, what is it, Sarah? I kind of just keen to get your take in a way on the sort of issue of the poll, which is like, I mean, clearly there is like, we are sort of in many objective ways sicker as a country than we were. COVID was enormous, and there was an underlying issue with the performance of the NHS and waiting lists pre-COVID, and that just plays out in some ways which are quite hard to measure, but that plays out, and you alluded to that. So that's one part of the story. I think most people would agree. Another part of the story that people talk about, I'm interested to get your take on, is just a shift in social norms, maybe reduced stigma, maybe just a sort of change in how we think about aspects of mental health, not just mental health, but that's one big example. I mean, how much of it is just we have evolved as a society and sort of come to a different place about people feeling differently about calling themselves, unable to work, disabled, in a way that people would have perhaps not done in the same way 15 years ago. Is that part of what's going on, or?
I think maybe. I mean, I think that there is definitely a shift. The discrimination that people felt, however, is still quite strong. So, yeah. I'm not persuaded by this idea that people truly believe that stigma and discrimination is at its lowest point. I think we've got evidence, certainly in mental health terms, it's probably at its highest point that it has been probably for 15 years. So I think that what we're seeing is something about the conditions that people are living in. I think it's got to do with poverty. I think it's got to do with those kind of perpetual lack of opportunity. And I'm a product of wonderful social mobility opportunities. My children will be the first children in my family who will not be born in poverty. Generational, immigrant family, so all of those factors do absolutely make a difference. And when I look at my children, I think about the social mobility opportunities that they and their friends are getting at school, I can't quite see them as clearly. So we can't underestimate the role of poverty. We can't underestimate the time it takes to get assessed, to get an intervention, and to get well. We also deliver the biggest psychological talking therapy service in Europe. And we should be proud of it, right? However, we exist within a recovery rate of between 50 and 60% for that intervention, of which we would not tolerate for breast cancer, as an example. So I think that there are some deep factors that relate to the health of the nation, the mental health of the nation, how we can get people assessed, how we can get them better, how we can get them into the workplace more quickly. And we've also seen a rollback in, when we talk about the accommodations that workplaces make, we've also seen a rollback in that too. So I think the circumstances in which people exist are very, very different.
Okay, that is important and rather bleak. But those things can change. Yeah,
they can change.
They can change. And things like adaptations at work, I mean, that is that's socially constructed, and we can work on that.
And Paul is right, that the public health strategy has to be deep. And sadly, we have annihilated our public health kind of focus in the
We've
government.
had a number. I'm not going to read them out because of the time, but we've had a number of questions of people sort of saying, "How big a deal do you think the cuts to public health have been in this context?" And I think we can answer that one now, folks, which is we think the panel's saying it's important. I just want to come to this issue about the structure of the benefit system. I mean, Eddie, you alluded to it, and Louise, you touched on it, and there's some interesting points in the report. I think it's worth drawing out. So, for those who don't follow this closely, basically, this sort of assessment about whether you get on disability benefits or kind of health-related benefits has in different ways become higher stakes over the last 10 years. So the concept, it is more binary. The underlying assessment doesn't force it to be binary. You could reach more gradated judgments using the data that we have through things like the work capability assessment. But basically, this is like more money if you pass, and then or basically zero, and that's a choice. And there's reasons for that choice, but I think people need to understand that, and that leads to a great incentive to try and get on one side of that, and very, very bad consequences if for whatever reason you're deemed to just fall on the wrong side of that. Louise, just take us through that. Just explain, unpack that a bit, and just how important do you think that is, and what would be some of the things you'd need to think about if you were going to take a different approach? And Paul, maybe let's hit you on that too.
Yeah, I think that's right, and I think sort of high stakes, I think, is exactly the right phrase to describe it. And Eddie, I think, brought that to life. That it's high stakes in terms of the pound amounts that you can get, as we showed in the slide. You can double your income by moving kind of onto these benefits. Or on the flip side, if you lose these benefits, your income halves. So I think that is a key part of it. But as Eddie said, that's only one aspect, and we also need to think about the experience of being a benefit recipient. And again, it is really high stakes between being in the standard looking for work group under universal credit compared to being in the health-related group who don't have those work search requirements. You're not at risk of being sanctioned if you receive this health-related element. You don't have this work search conditionality where you have to meet with work coaches and apply for jobs. And I think obviously that has some very tangible impacts, but I think plausibly there's just a wider, probably harder to quantify experience of just how you feel and how secure you feel in these benefits will be different if you are in the health-related group where you've got a guaranteed, steady month-on-month income, compared to if you're in the work search group. And just the final thing that we bring out is some of the cuts and changes over the recent years. For example, the benefit cap, I think, are important here because, again, some of these harsh edges of the benefit system exist to most claimants, but you can be exempt from these if you're in the health-related group. So again, that idea of kind of being able to achieve relative security exists if you're in that health-related group. Versus not. So I think our takeaway was just this design, and this whole system design is really important. That often what we've seen is this whack-a-mole approach of squeezing benefits in one place and narrowly thinking that might cut one element of spending by X%, but actually really it seems pretty clear what we're seeing is that that isn't a strategy for success, and I think we need to think about how to look at the system overall and really focus on the idea of security. How can we allow people to feel secure and feel able to take risks, even if they do have health conditions or disabilities?
Thank you, Louise. And Paul, anything on this high stakes issue?
Well, I mean,
a design feature?
And as I sort of tried to sort of emphasise is that we've had two major intensifications, right? We've had a work intensification of whether employers are sympathetic and sensitive to needs, and we've had the benefit intensification of conditionality and sanctioning. And it's unambiguous that the move towards JSA and welfare conditionality pushed a lot of people to migrate onto long-term incapacity benefits. And it is a binary system, as is being emphasised. But I would also just like to emphasise is the binary nature of employment, that you are, employed until you're on sick pay, and then you drop off the sick pay and you end up potentially in the benefit kind of system. And too often, the after relatively short periods on sick pay, employers essentially give up on you. Yeah, that you are, in a sense, left unsupported in capacity to return to work. And that essentially once your 28 weeks are out, you're definitely left without any kind of support infrastructure, and you're no longer connected to that employer. And that binary kind of like, are you with that employer and has it gone, has also got to go, in my view. That we've got to, in a sense, have a graduated state where we can do more positive things to try and hold people in employment rather than just trying to have the focus to drive people, often through conditionality, back into employment.
Interesting. So one thought is a more graduated approach towards how we think about benefits, and a second thought is a more graduated approach towards the employment relationship.
Yes.
Right. We've got a mic, so I'm going to take groups. We've got, I know who some of you are, but can you tell everybody else who you are? So we've got the guy in the front row, Tony, then a lady, second row, and then another lady there. So Alex, if you...
Tony Yates. I wonder what the panellists thought about the prospects of working from home and the fact that we've discovered that it is actually, in principle, possible, that could help, especially given that some of this is about mobility and physical ability.
Yeah, and that's an issue that the last government, as I think we're now supposed to call them, made a lot of. So it's an interesting one.
Thank you. My name's Grace Duffy. I'm from Bridges Outcomes Partnership. So we're a social enterprise which works a lot in the intersection between like housing, health, and employment, so helping people back to work and self-managed chronic conditions, etc. And in unpaid carers, actually. So Paul, thank you so much for raising this, because it's such an issue which is so often ignored. I'd say I really agree with you, Sarah, that when you take a more personalised and holistic approach, that's when you can see real success in helping people to move on and get back to work. But in our experience, there's real problems with the way that support services are kind of designed and commissioned. They're highly siloed, they're really short term, there's a lot of gatekeeping involved. But also in central government as well, so I recently left DLUC where I was working on the Renters Reform Bill, and even though there's so much evidence of the link between poor housing and health, and then that link onto productivity, it was super hard to actually make that economic case for intervention to improve standards. So I was just wondering if the panel's views on what are the kind of structural issues, the structural reforms that are needed to achieve kind of more effective services to help people get back to work.
Okay, thank you. That's a big one.
Mm-hmm.
That's a valid one as well.
Hi, I'm Kaylee Hignall from
Hi, Kaylee.
Citizens Advice. I had a question around the role of permitted work and working tax credits in that slowdown period that Paul was mentioning in terms of the trends on incapacity. They're both areas where I think we explicitly said in policy, part-time work, let's do it, it's a good thing. Lower pay part-time work, yeah, let's do it, it's a good thing. I feel in universal credit we've potentially lost some of that because we're pushing people into not fit for work categories. So interested in whether you think it played a role or not.
Okay, let's take those three. Don't all answer all of them, otherwise we won't get any more. We'll try and take one more round. Working from home.
Can I just say, the working at home thing I think is really interesting, and we're definitely seeing, it supports well-being for all sorts of reasons. However, there is an emerging caveat, which is, as an employer, how do you maximise your duty around well-being when sometimes you just can't see individuals? And I think... So we're starting to see the consequences of that on individuals and in workplaces in terms of an overall sense of good, positive, strong mental health and well-being. Mm-hmm. So I think the jury's still out from a mental health perspective, and we certainly, I don't think, have got it right. And the balance, I think, is... certainly I'm concerned looking around and thinking, well, many of the things that employers did they can no longer do because of the working at home thing. And I just want to tackle that question before I pass on to somebody else, but just the issue of sometimes I think when the evidence is so strong, what more do we need to do? Interpretive dance? I have no idea, right, at this stage, because the evidence is really strong, right? And I think for us, the challenge is to provide those, solutions effectively and try and kind of, take them into that kind of economic pragmatic, possible spaces of, you know, these are doable. But fundamentally, what we're seeing here is an ideological issue around how we consider and how we support vulnerable people, which is fundamentally problematic in this country as it stands.
Can I ask you, in the sense that pushing that a little bit, is what's the evidence around long-term worklessness and benefit receipt on mental health?
What do you mean?
Do people get worse?
I know. I mean, I don't think that it's people get worse. People don't thrive, I guess. So the issue is about languishing on benefits without positive support and help, and that's part of the problem. So when austerity came into place, all of the stuff around prevention and what keeps people well with very serious mental illness were withdrawn.
Okay, I'm going to get Eddie. You come in. Which of those did you want to pick up on?
Oh, there's so many.
But the kind of part-time work point is.
I think there's some evidence that universal credit and its more flexible rules about intermittent or part-time work have worked for able-bodied people to kind of work. I think it's completely failed for people with disabilities, and in particular people with mental health issues. It's just we still.
Why is it?
Because if you want to protect your status as being sick or disabled within the system, you have to fit within these very narrow rules around how many hours you can work, how much you can earn, and which particularly doesn't work for people with mental health problems where it may be episodic. So you can earn a lot of money in a short period of time and then earn nothing for months. Yeah. It's just that didn't work 30 years ago, and despite numerous politicians and reforms saying we're going to make all this easier, it's still completely inflexible and it doesn't work for people.
That's Paul. Quick fire.
Quick fire. I mean, I do want to sort of re-emphasise the quality of the labour market for many people who are trying to move back from benefits. Yeah, and those kind of labour market regimes are not sympathetic towards people who have intermittent health problems, mental health problems, and you sort of mentally think that 0-hour contracts would be perfect, and actually they're a complete disaster. Right? Yeah, right. I'm working from home. Yeah, my daughter's a digital nomad. That's a great phrase. And I sort of want to say the same thing, slightly different, is that getting access to work kind of support for working at home kind of is more difficult, yeah, and trying to open up that section of a labour market which is growing to people who've got serious health problems is a problem in itself, yeah. Is that trying to make that? I mean, working at home has lots of potential benefits, yeah, but getting people connected to that labour market and enabling them to, we're talking a lot of people are less well educated. That's not the segment of the labour market which is easy for people to move into, and it requires a different kind of support and thinking than other labour market opportunities.
Okay. Are there any burning questions? They have to be really does anyone really got something they want to ask who hasn't had a chance to ask something? We've got a gentleman here. Yeah, you have your say, and then we're going to bring the poll back up. And there's okay, we'll take this one. They're going to be pithy questions.
Okay, Raj Patel, Understanding Society. I think I got the message about disability increasing across the population, but I'm wondering whether we're not shining enough light on the 50 to 64-year age group, which I suspect is quite diverse, and trying to get underneath to understand what's actually going on there.
Okay, I'm going to speak up for that age group. I've got a vested interest. And there's a gentleman back there. Tell us who you are.
I'm Willie Morris with Tendo Consulting. So we talked a lot about getting people back into work, but health, and especially mental health, is pretty private. And so if I have a colleague who's having a mental health problems and I don't really see it, all I see is that they're not returning emails, they're not really doing their job, and I might not be legally allowed to know why that is. So I guess how do we balance people's right to privacy around mental health and health with also kind of compassion and understanding from their colleagues?
Okay. Fine, let's come back.
That's a tough one.
It is a tough one. We're going to come back to the panel briefly. So, who was this 50 to 64s as being a key sort of age group where a lot of the people are in that age category who then go on to.
I think
have
realistically, if
health
you look at the benefit caseload, that age group would be the kind of employment they're going to be able to get back into. Realistically, it's like, is it worth the effort? Because the benefits, the income is so low that you almost become disconnected from that work. And so whatever the suggestion, there are a couple of things that definitely won't work. One is we're not going to write anybody off. When politicians say that, that means that's exactly what they are doing. And when they say we're going to focus on what people can do, not what they can't do, that's been said so many times over the last 25 years. That's another meaningless statement. If you hear anybody saying that, you know they've not got a clue what to do, and whatever they come up with will be completely the wrong thing.
Okay, that's what we call a seasoned remark. Louise, anything on this kind of age demographic point from our numbers?
There's a lot of us.
Yeah, it's a big part of the population.
We're growing in our numbers.
Exactly.
Yeah. I think there's 2 points. I think rightly that we and others that have focused a lot on the rise in disability, particularly mental health problems among young people, but I think we do need to remember just that levels of disability are so much higher among that older age group. And I think the second one, again, is just this idea of intentional policy choices now feeding through. So we've intentionally increased the state pension age. There were changes to mixed age couples, for example, within universal credit that mean intentionally we have more older people in receipt of working age benefits. And we now have a universal credit system, which again was designed to, encourage people to work, make work pay. But I think we now really need to think about, how can we make that true for people who, are in their 50s or 60s, who the evidence suggests if they've been out of work for a long time, will really struggle to get into certainly full-time, high-paying work. And so I do think part of it comes down to part-time work and thinking how can we, design a system that, for those people who can work full-time, that pays, and that is a possibility. But for those people who are not working at all but who might be able to do part-time work, I think we should really deeply think about how to make that a viable opportunity. I don't think it's easy to balance those two things, but I think at the moment there's just not enough attention to that.
Thank you, Louise. I promised we wouldn't overrun. I need to keep that. So I'm going to stop the questions there. Can we just bring up the poll, please, just to see what people said? If we can do that. What are the answers? What did you all say? We said, we were split, completely split between sort of basically destitution, levels of support in the social security system, and just poor design of social security. But also, obviously, the NHS is a big factor in your mind. And change social norms significant too. So a bit of everything, those two stand out. Kind of was sort of implicit in the question, really. That was a bit of everything. Okay, I really, that was great. And we could have gone on for much longer. I apologise to people online, lots of good questions. We sort of touched on some of the themes. We didn't dive into all their questions, so sorry. But that was a good, lively discussion. I think we made some progress in identifying what some of the pillars of a more considered approach might look like if you were really trying to sort of support more people into economic activity rather than just having a kind of very binary system. And we also certainly, I think, all emphasise that you need to think about employers. You need to think, obviously, about preventative health. You need to think about housing. All of these things are actually integral to these issues. Let's hope that those sorts of thoughts land on Whitehall desks at some point. We're going to be doing loads more work in this area here. We've got a number of further papers coming up on this theme, so please look out for them. We've got another event on Tuesday on a labour market, what's happened to the labour market over the last 14 years and what are the different parties saying about labour market reform. So if you are into these things, please come back. I want to thank again the Nuffield Foundation for supporting this work. That's how we are able to do it, so we're indebted to them. And I want to thank all of you for coming today. Really, really great questions. And please join me in thanking a really good panel. Thank you.